Okay, and we are live. Hello, web shadowers. Welcome to our second summer session. For anyone who wasn't able to attend our first session last week, we will be hosting 1 to 2 sessions a week on Tuesdays and Thursdays in the evening for our summer semester of web shadowers. We're very excited for what we have coming up this summer. I want to thank you all for attending our session this evening. With that being said, today we have the pleasure of hosting Dr. Schüpper again, who will be teaching us about neurosurgery. As always, please remember that the Google form to fill out for your attendance will be posted in the chat box and in the description of this video at the end of the session. With that being said, Dr. Schüpper, you can get started whenever you're ready.
Awesome. Thank you so much. Thank you to Web Showers for the opportunity to come and present again. I had so much fun this winter talking to you guys about intracranial pressure management and couldn't wait to have the opportunity to present again. So we have a lot to present tonight. We're going to be talking about neurotrauma in the acute care setting and how we as neurosurgeons intervene on trauma of both the brain and the spine. So without further ado, let's get started. So just to give you guys a brief intro, I know some of you attended our last session, but for those of you who are new, so my name is Alex. I'm a second-year neurosurgery resident at Mount Sinai in New York City, which is a large health system in Manhattan, as well as some of the other boroughs in New York City. As far as my background for undergrad, I attended Johns Hopkins, which is in Baltimore, where I studied both neuroscience and psychology. I played varsity baseball there. I was involved in student government. My senior year, I was student body president. And when I wasn't on the baseball field or helping run student life, I conducted both trauma and neurosurgery research. And it was during my time in college that I really developed a passion for neurosurgery. I then went across to the left coast to UC San Diego, where I attended medical school, had a great time there. It was my first time living outside the East Coast, and it was a really awesome experience. And then I came back here to New York to be closer to friends and family and to attend Mount Sinai, which is a fantastic program that I'm very proud to attend. When I'm not in the operating room, I have several hobbies I'm really passionate about. I love CrossFit, working out. I love hiking. I was just in Yosemite last week, hiking around, which was a ton of fun. In the wintertime, I love snowboarding, traveling, seeing the world, and cooking when I have a chance. As you can see in some of these pictures, these are some of the places I've been recently since starting residency. And then a lot of people ask what I'm interested in within neurosurgery, because neurosurgery is a vast field with many subspecialties. And some of my research interests include complex spine, which I'll show you guys an interesting case about, malignant brain tumor, such as glioblastoma, as well as pediatric neurosurgery. So I'm sure some of you guys have an idea of what neurosurgery is, but for those of you who may not be so familiar, neurosurgery is a specialty that pertains to the surgical management of diseases and disorders of the nervous system. Now, many people think that being a neurosurgeon is synonymous with being a brain surgeon. But actually, a lot of the surgery we do is outside of the head. It includes both the spine as well as the peripheral nervous system. Now, like many other specialties, we're divided into several subspecialties. Again, as I mentioned, spine is very big in neurosurgery. This includes everything from minimally invasive surgery to big complex deformity surgeries like scoliosis corrections. Neurosurgical oncology includes treatment of tumors or malignant lesions of the brain or the spinal cord. Skull-based surgery involves intervening on diseases such as pituitary lesions, pituitary tumors, vestibular schwannomas, any lesion of the skull base. Cerebrovascular is a major field in neurosurgery, includes management of stroke, aneurysm, AVMs. And then pediatrics, as I mentioned, is another big specialty. So these are just some interesting cases. This is a big malignant brain tumor here. These cartoons show that the nervous system really is your entire body when you think about it, when you include the peripheral nervous system, the spine, and the brain. This is a cartoon of an arteriovenous malformation. And then this here on the bottom left is a scoliosis correction. So there are several facts and myths that I just very briefly want to go over before I give you guys some cases about neurotrauma. So some facts about neurosurgery: we are a very diverse field, as I just mentioned. We have a lot of subspecialties within the field. Technically, it's very challenging. Everyone says, oh, you're in neurosurgery, you must have great hands. The reason people say that is because we operate on very high-priced real estate. We operate in the brain, in the spine, specifically around the spinal cord, areas that are very unforgiving compared to different parts of the body. So it is technically very challenging. I will say not everyone is born with fantastic dexterity, but as Malcolm Gladwell describes, with 10,000 plus hours, you can really master a technique. And in neurosurgery, we truly embody that you just have to practice and repetition to do things thousands of times before you're truly proficient. We do have a very strong research component. We tend to be one of the more research-heavy specialties. This is because we're always looking for innovators in the field. We're looking for people who want to bring neurosurgery forward and adapt these new technologies. And really also because we don't know very much about the brain compared to many other organ systems. So we're always looking for people who are on the cutting edge and trying to discover a vaccine for glioblastoma or a new treatment of disc herniations, right? New things like that. So we tend to be very research oriented. Neurosurgery is incredibly rewarding. It really epitomizes the high stakes, high reward cliche, if you will, in that we're operating on high fidelity territories, but when things go well, it can be really rewarding. You can totally change a patient's life. And like many other surgical specialties, it is well compensated. Now, there are some misconceptions of neurosurgery that I want to discuss very briefly with you guys. And I did mention this in the beginning, but feel free, guys, type in the chat box if you have any questions, comments. I want to make this as interactive as possible, so feel free, fire away, and I'll try to get to your questions as much as possible. So there's a misconception that all patients in neurosurgery have poor outcomes, or they have poor neurological status, or that they're comatose. This isn't true. While there is the occasional patient that has a bad outcome, say they have a high-grade ruptured aneurysm or have a really bad brain tumor that they're not responding well to treatment, these are definitely not the majority of our patients, and most of our patients actually do really well. It's also a myth that you have to be a top student at the top medical school to become a neurosurgeon. Just because you didn't go to Harvard Medical School, it doesn't mean that you can't get into neurosurgery. I know neurosurgeons who came from all different types of medical schools here in this country, international medical schools, DO schools, or osteopathic schools. There are many ways to become a neurosurgeon. And going off that vein, there's also a myth that women can be neurosurgeons. While there is a big gender gap in neurosurgery, just like every other surgical subspecialty, this is something that in neurosurgery we're actively trying to change. So if you are a woman and interested in neurosurgery, I cannot recommend it more. You will be highly, highly regarded. Every year we're looking for more women in our program. One of our interns is a female and she's fantastic. And we have several amazing faculty who are female neurosurgeons who are some of the most meaningful mentors to me so far in residency. And going along that vein as well, if you're an underrepresented minority, there's definitely a place for neurosurgery for you. Do not be discouraged based on looking at the demographics of neurosurgery, that it's a male-dominated or dominated by certain races. I cannot recommend it more. If you're an underrepresented minority, we're looking to diversify neurosurgery, okay, to increase the number of African Americans in neurosurgery, of Native Americans in neurosurgery, Latinos in neurosurgery. These are all hot topics that we're really actively working on. One of our incoming interns is African American from UCSF Medical School, and he's fantastic. And we're incredibly excited that we're getting him because one of our chief residents is also an African American who unfortunately is leaving our program this year. So I cannot recommend it enough if you're underrepresented minority. And then finally, we are not Grey's Anatomy. We try act maybe sometimes like we're living the McDreamy life, but it's not true. We work really hard. We don't just hang out, messing around all day. So definitely not the case. So as I summarized before, I started at Johns Hopkins, actually came from Philadelphia, hence the Phillies hat. I then went over to the left coast, UC San Diego for medical school. And then wanted to be a little bit closer to home. So I came back to New York for my residency training. And that's how I got here. So very quickly, just gonna answer a question or two before I get into intracranial pressure management. So how do I practice surgery? You can't just allow someone to practice on them. So that's a great question. So we do actually practice or train on people, right? In a residency, which is essentially an apprenticeship. I have more senior people than me guiding me through surgeries, and it really is a graduated autonomy system in residency training, where as a surgeon, I'm learning new techniques, I'm learning how to do certain interventions, and as I become more comfortable, I'm given more responsibilities and allowed to do more. And that by the time you're at the end of your second, your third, your fourth year, you're really doing surgeries on your own. But you get to that point by doing hundreds, if not thousands, of surgeries with people guiding you through it. So you're never asked to do something that you're not capable of, and it's really a stepwise approach. And then one more question before I keep going, because I want to be very cognizant of your guys' time. What are some of the differences between trauma, neurosurgery, and neurocritical care practice by neurologists? That's an awesome question. We're going to get to that. So very briefly, so talking about neurology versus neurosurgery, which is an excellent question. And a lot of people consider both fields because we deal with the same organ system. We deal with the nervous system. The difference is neurologists manage diseases and disorders of the nervous system from a medical standpoint, meaning they provide medical treatments, and we provide surgical treatments as surgeons. So there are certain diseases and disorders that are warranted by medical management and others by surgical management, and some by both. For example, MS, multiple sclerosis, is a medical disease. We don't treat that with surgery. We treat that with certain medications. We actually have very good medications nowadays for MS, versus, on the other hand, take a brain tumor like meningioma, a benign, slow-growing tumor in many cases. A meningioma cannot be managed medically. To cure a meningioma, you have to perform surgery, go in the brain, and remove it. And for a low-grade meningioma, that's benign. Once you remove the tumor, the patient is cured. So these are the two extremes. However, there are many diseases or disorders where both medical and surgical management apply. And that was a wonderful transition, because let's talk about intracranial pressure management and traumatic brain injury. So let me paint this picture for you guys. You have a patient, it's a 35-year-old guy brought in by the paramedics to the ED, or the emergency department. He was in a high-speed motor vehicle collision. There were no witnesses at the scene. When the paramedics got there, he was mumbling, he was confused. So after he got there, he started vomiting, and non-bloody, non-bilious emesis, which is fancy words for his blood was not green full of bile, and was not bloody. He has no other signs of trauma. Trauma team said he has no other injuries. These are his vital signs, which I'll just tell you, overall pretty stable. A guy who just suffered a trauma might be a little tachycardic. That's totally normal. He's breathing okay. So what's your next step? So fire away your questions. I know there's a little bit of a lag time, but type in what you guys think as far as the next thing to do. So imagine you are the intern in the trauma bay, and you see this guy, he's mumbling, vomiting. He was just in a high-speed car crash. It's not really making sense. And the trauma team says he has no other injuries. What do you want to do next? So while you guys are typing those answers, I'll answer the next question. So the average duration of surgery varies tremendously. Today, I did a surgery that took 1 hour. That was a 1-level microdiscectomy. Someone had a disc herniation, and we took that out. In the past couple of weeks, I've done a surgery as long as 12 hours. That was a complex cranial case. It took about 12 hours. So it can vary dramatically. All right, so perfect. You guys are so smart. Neuro exam. Always examine the patient, right? You're never going to be wrong by saying the next thing you do is you have to see the patient, right? Do a neurological exam. And so you do that. And so the GCS is 8. Now, I want you guys to type what you think GCS means. And so that's part 1. Part 2 is GCS of 8, normal or abnormal. Okay, so while you guys are typing that, wow, you guys are really quick. I mean, Sophia just knows all the answers. All right, so this is his neurological exam. So his eyes are open to noxious stimuli. This means that when you just yell at him, say, hey, Mr. Smith, he doesn't open his eyes. But when you pinch him or you give him a big sternal rub, he'll open his eyes. His right pupil is 4 millimeters and sluggish. Left is 3 millimeters and brisk. This means when you shine a light, how quickly the pupil constricts, which is a normal brainstem reflex. I will just tell you this is abnormal. You shouldn't have one sluggish pupil and one brisk pupil. He does have a cough reflex. He has a gag reflex, a corneal reflex. These are all brainstem reflexes that you should have, that all of you, if you're awake and alert, have right now. He's extensor posturing, his right upper and lower extremity. What this means, guys, is he's sitting in bed and his arm is going like this. His arm is straight out and his leg is straight out with his toes going down. He's not following commands. So you ask him to show 2 fingers, squeeze your hand, he's not doing it. Okay, so 8 out of 15, 8 is fully alert, 1 being coma. Close, very close, almost, not quite. Can anyone answer of why that's not correct? I'm just gonna keep rolling through this. All right, so next step. So we got this, we have this exam from him. I will say, I'll just give it away, this is a very concerning exam. If I'm the guy, the neurosurgeon on call, and I get this exam, highly concerned. Okay, I'll tell you why. There are a couple of reasons. One, his pupils are unequal. This is called anisocoria, when your pupils are not responding equally. He's extensor posturing on one side of his body. He's not following commands, okay? And a GCS of 8 is actually pretty low. Exactly, Sophia. All right, sorry. Sophia's typing in all the answers for all you guys, but whoever answered it is correct. So 8 out of 10 is pretty low. It's actually considered, it's on the cutoff of a severe traumatic brain injury. 15 is the highest. If you guys haven't fallen asleep in this lecture yet, you are all 15. If you have, probably a little bit less, sorry. 3 is the lowest you can get on the GCS scale. There's a coma. The reason, if you look up here, guys, is GCS is broken into 3 categories: eyes, verbal, motor. The lowest you can get is 1 point for each, so the lowest score is a 3. And again, you guys are all 15 if you're still awake with me. So the next step, you have to get a CT head, right? It doesn't matter if you're the best neurosurgeon in the world. Just getting this exam, you do not know what's going on without a CT or without any type of neuroimaging, brain imaging. You have to see what's going on in the head. So you get a CT, and this is what it shows. Now, very quickly, guys, I know it takes some time to come through to the chat, but type in what your diagnosis is. What do you guys think? I'll just tell you, this is abnormal. This is not a normal scan. Let me help you orient. I don't know if you guys can see my mouse, but right here, which is the left side of the picture, this is the right side of the brain. This is, oh, perfect, thank you. This is the left side of the brain. So the reason is just the orientation of the CAT scan, left side, right side. Diagnosis, question mark. Okay, midline deviation or midline shift. That's correct. They have that. The reason is because this is midline. Okay, and it's definitely shifted this way. Okay, subdural hematoma. Any other guesses? Everyone think it's subdural? Okay, some people are saying epidural. Any other guesses? Herniation. Awesome. Love where your head's at. So I'll just tell you guys, this is a subdural hematoma. Now, how do I know that? How do I know it's a subdural? I know it's taking some time for the questions to come in. But just because we're trying to get through this, I want to get through 2 cases with you guys and save time for questions. We're going to move a little quickly. So there are multiple types of intracranial bleeding or hemorrhage. This is one of them. This is called subdural hematoma. This is another version of a subdural hematoma, it's just on the left side. It's the same type of bleed as that one. So this right here is a subdural hematoma. If you guys can't see where it is, follow my mouse. All this bright stuff here, or hyperdense on CT, this is all blood. And this is not just blood, it's acute blood. It's blood that has not been there for very long, just a couple hours. This right here is an epidural hematoma. Now, how do I know that? I know that for a couple of reasons. One, it has this nice crescent shape, which a subdural doesn't have. And as you can see, it's cut off here and it's cut off here. Now, why is it cut off? This is kind of a higher level question. Some of you guys probably know, but it's cut off actually by the cranial sutures and where the dura is pinned up against those sutures. So if you're an epidural hemorrhage, or epidural hematoma, you are above the dura, or the lining of the brain, the meningeal layer. the covering of the brain, if you will. So this bleed is on top of it. So it's in the space below the skull, below the bone, and above the dura, which will allow blood to flow until it gets to the suture, which the dura is up against. So it cannot go beyond that point. A subdural hematoma, subdural, like think about the word, if you break down the word, underneath the dura. So it's not restricted by the cranial sutures. So as you can see here, guys, this bleed expands the entire left side of the hemisphere. This right here is called an intraparenchymal hemorrhage, or IPH, or ICH, intracerebral hematoma. Okay, this can be caused by things like hypertension. Amyloidosis can cause bleeds like this. And this here, what do you guys think this is? This nice little star pattern. Let's see who can type in the fastest. So it's not a subdural, it's not an epidural, it's not an ICH. It's a different type of bleed. The only one I haven't mentioned. I'll give you a hint. It's a type of bleeding you get when you have a ruptured aneurysm, most of the time. When you have an intracranial aneurysm that ruptures, it gives you this type of bleeding. Do you guys know what it's called? So it fills these cisterns. You guys are so smart. So not ventricular. So these are the ventricles. These are the temporal horns. This is the fourth ventricle. This is called subarachnoid hemorrhage. You guys are incredibly smart. It's in the subarachnoid space, which is also where your vasculature is. So when you have a ruptured aneurysm, this is where the bleed forms. All right, so really important. I'm going to zip through this. The only thing you have to know, or that's most important to know when it comes to management of traumatic brain injury, is the Monroe-Kellie doctrine. It's a fancy eponym for the fact that there are three things inside of your head. There's brain, there's water, which is in the form of CSF, and there's blood. It's in a very regimented amounts based on the volume. Now, the only things that matter is the relationship between pressure and volume. Because the skull, you can think of as an enclosed box, a locked-in box, okay? Those three things, brain, water, and blood, they're in a set amount, and if you increase the amount of things in a fixed volume, the pressure will go up, which is why if you have any type of bleeding in the brain, you have any other reason to have more things inside of the head, it doesn't have to be blood, it can be a tumor, it can be an infection, it can be any type of swelling. These can all cause the pressure inside the head, or the ICP, intracranial pressure, to go up. So just think of this, it's the relationship between pressure and volume, and this is why we manage traumatic brain injury. So don't worry about this. It's just all regulation. Your brain auto-regulates like different parts of your body, essentially just to maintain a constant amount of blood flow given different perfusion pressures. So why this matters is because of herniation. Some of you guys are super smart and you already said it. So herniation is really important. Why is this so important? What do you guys think? I'll give you guys a couple seconds of why you think herniation is so important. You guys know what herniation is? You might know the word from this. It's the first half of that word. So what do you guys think? Why is herniation bad? I'll give you a hint. It's the same mechanism as this. Okay, build up of pressure, great. Shifted tissue, fluid in the brain, excellent. These are all really great answers. So the reason it's bad is because when your brain herniates, remember the Monroe-Kellie doctrine that we just spoke about, okay? Enclosed box, you increase the amount of stuff, the brain is trapped inside this closed skull. It can't go out, right? So where does it go? It goes down. And what's living down there below the brain or at the base is your brainstem. And why is your brainstem so important? Your brainstem is so important, guys, because it controls the most important things to keep you alive. It controls your ability to breathe, the ability of your heart to regulate. Basically, a lot of your homeostatic behaviors, a lot of your autonomic behaviors, everything that you don't have to think about to keep you alive, that your body is doing because it likes you and because you don't have to pay attention to it. Most of these things are controlled by your brainstem. And when you have increased pressure and you have increased pressure in your brainstem can no longer function and you cannot survive. This is why it's important. And this is why we treat high intracranial pressure so aggressively. This is just to show you guys there are many reasons to have high intracranial pressure. Having a traumatic brain injury is just one type. You have brain tumor, you can have different types of infections. You could have a clot in one of the veins in your brain, a lot of different reasons. So there are many ways to manage intracranial pressure. We just look at the time. All right, doing all right. So there's a stepwise approach, okay, just like many things in medicine. The first thing you do is you have to manage the patient's airway. If you guys remember ABCs, it's the most important thing in terms of trauma, emergency medicine, acute care, very important, okay? If you aren't managing the patient's airway and the patient loses their airway, they're dead. No one cares about a neurological exam on a patient that can't breathe, right? So even though we think the patient's neurological exam is the most important, at the end of the day, we're doctors, right? We have to treat the patient. Airway always comes first, okay? If the patient doesn't have an airway, that's it. So if their GCS is less than 8, that's that Glasgow coma scale we talked about, how alert the patient is, you have to intubate them because the patient is not conscious enough to protect their airway. Hyperventilation is interesting. It's really important. I won't go too far into the mechanism behind it, but essentially what you're doing is while you're breathing off, when you're hyperventilating, you're breathing off CO2, which affects the pH of inside of your head, and it causes the blood vessels to constrict a little bit more, which prevents more blood from flowing into your head, which decreases the pressure. However, this effect only lasts for a couple minutes. Positioning is so important. So guys, a lot of you are pre-med students or medical students. If you're working in the emergency room or trauma bay, you can save this person's life without being a neurosurgeon or without being a trauma surgeon. All you have to do, if you're concerned this patient has a really bad head injury, if you see their heads flat, sit them up, keep their head straight. Okay, if they're in a cervical collar because we're concerned for a spinal cord injury, you can loosen that. These are things that can drastically affect the intracranial pressure of the patient. Okay, why? It's just like gravity. Hold your arm down for a couple minutes, and you'll look at your veins like you just got an awesome pump at the gym. Why is that? It's because blood flows in that direction with gravity, right? So it's the same thing with your head. Your head is down, blood is going to pool in your head, right? Try doing a handstand for a couple minutes, right? You'll start to feel your head's getting a little heavy. It's the same thing. Sit the patient's head up, and you'll encourage venous outflow from the head. And then sedation is also really important, guys, particularly in a patient that can't protect their airway. You want to sedate them to decrease the metabolic rate in your brain. So out of all the organs that you have, the brain is the most metabolically active, and it cannot store energy. Unlike organs like the liver, which can store glucose, the brain cannot. So it's constantly using energy. So we want to do whatever we can to decrease the metabolism of the brain. So there's just a couple more pictures. So on the left is an epidural, as we talked about the suture lines, right is subdural. We're gonna get this into your guys' head, if you remember one thing. All right, so what we do in addition to that is we can give some really powerful medicine. Again, traumatic brain injury is a great example of a neurological disorder treated both medically and surgically, okay? To answer your guys' question from earlier. So there's some really important drugs that we can give to decrease the pressure inside of someone's head in the setting of trauma. We can give them really concentrated salt. Now, I'm sure you guys are thinking like, all right, salt, like salt water. What's the big deal? The reason is because it creates this gradient that helps suck water out of the brain. And guys, about 80% of the weight of your brain is actually water. Okay, your brain is very buoyant. Okay, and the mass of the brain is actually pretty water intensive. So we have a lot of opportunity there to suck water out of the brain. Additionally, there's a drug called mannitol. It's a really big molecule that essentially just creates an osmotic gradient that also allows water to come out of the brain. You can't give it in the patient with renal failure because it's excreted by the kidney, and they can their kidneys can get really sick quickly from it. But in the right patient, mannitol can be really effective. And then this is just to show you, if you have high intracranial pressure, ICP, for a different reason like malignancy, steroids can be really important. And then in an infection case, antibiotics obviously can be, if it's a bacterial infection, obviously. So then just to wrap up traumatic brain injury, the next step, if medical therapy doesn't work and these initial maneuvers don't work, is when we get involved and when we really have to act as far as surgeons. And so go back to that picture of the Monroe-Kellie doctrine I talked to you guys about earlier and said this is really the only thing you need to know, because it's true. Think about it. You have a fixed box, a closed box with 3 things in it in set ratios. Now you have increased bleeding. Now, how do you decrease the pressure? One way is to take some things out. Another way is you can increase the volume, right? Say we open that box. We no longer have that high pressure, right? Because we now have an increased volume. This is essentially the entire concept behind intervening on intracranial hypertension in the trauma setting. So one way to do that, an alternative technique, actually, what I mentioned first, is to take things out. You can actually take out cerebrospinal fluid. Now, how do you do that? I'll show you guys in a sec. An alternative is we can take them to the operating room and we can remove part of the skull. We can take off half of their skull, as you see here in the picture. This is called a decompressive craniectomy. An alternative is if they have a bleed in the cerebellum or in the infratentorial brain, we can perform something called suboccipital craniectomy, where we take off the back of their skull and the base of their skull. Okay, and this essentially just creates an infinite volume, so the pressure can go down. This is what I was talking to you about with how we can take cerebral spinal fluid out of the brain. What we do is we insert a catheter inside the ventricles, the fluid-filled spaces of the brain, the little black C-shaped things that you guys see in the CAT scan. So we can put a tube in there and we drain off the cerebral spinal fluid, which will decrease the pressure inside the brain because we're taking out some of the products. And then finally, if none of these things work, we can paralyze the patient. And I'm sure you guys have heard of a barbiturate coma or medically induced coma, as they say in television. So essentially what this is we're shutting down the brain. We're doing the factory restart. And we can use pentobarb. It's really, really dangerous drug. We almost never do it. I've only seen it, I think, maybe 4 or 5 times. It's very uncommon. It takes a long time to reverse. It can actually take 2 to 3 days to get a patient back out of a coma after you stop the drug. So it's really a last-ditch effort. All right, so any questions that you guys have before I head from the brain down to the spine? Again, there will be time for like general questions after, but if you have specific questions about traumatic brain injury, now's a good time to ask. Give you guys about a minute. So as far as organizing the rest of the hour, I'll spend about 15 minutes on spinal cord injury, maybe a little bit less if I can, and then the remainder of the time is your guys, any questions you guys want to ask. All right, thanks, Sophia. All right, so spinal cord injury. So to give you guys another little case vignette, 53-year-old female brought into the emergency department. She fell 12 feet off her ladder while working on her roof. She didn't lose consciousness. She remembers the whole thing, but after the fall, she couldn't move her arms or legs. So the paramedics were called, immediately brought her to the emergency room. So we'll get into how to manage this patient in a sec. But first, I want to teach you guys about the spine. So very quickly, rapid fire, I want you guys to list in order the green, the orange, the pink, and the blue. The blue and the purple there at the bottom, you can list together if you want, or you can list one of them. These are the different anatomical regions of the spine. So we're going to start at the basics, and then I'm going to kind of go through as far as spinal cord injury. Because you can't really understand spinal cord injury if you don't understand the spine. And it's hard to do it in 10 to 15 minutes, considering this is a 7-year residency program, but I'm going to try my best. You guys are so smart. Perfect. So cervical, top 7 bones there in green. Okay, we start from the base of the skull, go down to C7. Thoracic, you have 12 of them. Okay, it's the middle. Lumbar, the bottom. Okay, which sits above the sacrum and the pelvis. Okay, and the coccyx, exactly, or the tailbone, as some might say colloquially. So 31 pairs. Okay, this is what keeps you upright. This is what keeps your structure. It keeps you staying tall. So talking a little bit more about the spine is not straight, right? Even when you're standing up straight, your spine is not actually straight. Your spine has a couple really important curves that give you your posture and allow you to walk, right? This is the difference between us and the quadrupeds that, like your dog or your cat, okay? The curvature of our spine is very different. We have a cervical lordosis, which is curved, let me show you here, curved this way. Thoracic kyphosis, which curves the other way. The lumbar spine curves the same way as cervical spine or lordosis. And then you have a certain angle of your sacrum, which is really important. And it kind of defines your pelvic tilt and the angle of your pelvis, okay, which helps keep you erect. Now, the spinal cord, you guys may or may not know this, but the spinal cord sits right in the middle here, okay? So as far as orientation, your belly's here, your back is here, okay? It's the skin of your back, okay? So your vertebral body is actually in front of your spinal cord. Some of you guys might not know that. Spinal cord's here in yellow. You have these discs, these little spongy things that sit between the bones. And then you have some very important bones that maintain structure, such as the superior articulating process, connecting to the inferior articulating process, which provide the joints, which allow the bones of your spine to move. And then you have other bones that are not as important, like the spinous process, which actually doesn't provide any stability. You can break your spinous process and nothing's going to happen. Your spine is not going to be unstable. So it's really important to understand the anatomy of the spine and which bones represent the stability and the structure and maintain the integrity of the spine. So there are a lot of ways to injure your spine, as I'm sure you guys can imagine. So it's separated really, especially in the cervical spine, the upper spine, which is the case that we're talking about. There are 3 major types of injuries: compression injuries, or when you have kind of axial loading. So for example, like if someone is diving off a diving board, it hits their head in the bottom of the pool, okay, that can cause a compression or a loading injury. You can have flexion, extension, distraction injuries where the bones actually kind of shift and shear off each other. And then you can have rotational injuries, which can happen especially after like high-speed motor vehicle collisions, where the bones can actually twist off each other and they can disrupt the joints, which I just showed you guys where they're located at. So understanding spinal cord injury is really important. The exam in spinal cord injury is incredibly important. So with spinal cord injury, we don't worry as much about the mental status like we do with traumatic brain injury. We worry about the motor function and the sensory function. These are really important because your spinal cord doesn't, so think about your spinal cord as kind of everything below the brainstem, below the base of the skull. And it provides both motor and sensory function to your entire body, your shoulders, your arms, chest, your back, your legs, okay? So understanding where each nerve is responsible for is really important in terms of grading a spinal cord injury. There's this really complex system called the ASIA system. So this is like the classic sheet that you fill out of how to grade a spinal cord injury. Essentially, guys, it boils down into this, okay? There are 5 subclassifications. It goes from A to E. A is a complete spinal cord injury. This means that there's no motor or sensory function below the level of injury. E is normal, that if you guys have an intact spinal cord, you have normal motor and sensation to all of your extremities. Now, what do you do? Very important, guys. So if you're walking in the street and you see someone you're concerned with spinal cord injury, most important thing is spinal immobilization. What does that mean? This means that you're not turning the patient's neck, you're not turning their body, you're keeping them still, you're keeping them on their back. Okay, you're finding a way to safely get them on their back with keeping them in line. What this means is that their neck does not move relative to their head, relative to their shoulders. Everything moves in one. Okay, you want to keep that stability. Same like in traumatic brain injury, ABCs, airway, always the most important. If the patient is not protecting their airway, they don't need a spinal cord because they're not alive, right? Airway is the most important. Then maintain blood pressure, right? Circulation is very important as well. They have to be perfusing their spinal cord or there's no sense protecting it. Then you want to do a brief motor exam to understand what they can do and what they can't do initially. So in terms of in-hospital management, so as you can see here, a lot of these things are the same, right? We still are maintaining immobilization until we really know what's going on and how the patient's doing. We want to control their movements. So if we're concerned for cervical spine injury, we'll put on a hard cervical collar, as I mentioned before. Airway is always important. If they can't protect their airway, we have to intubate them. We have to put in a tube down their throat and put them on the ventilator to breathe for them. And then we want to do a very thorough neurological exam, essentially fill out that sheet of every level to see what they can do, what they can't do. Steroids are a very long topic to discuss in spinal cord injury. There initially were some papers that suggested that methylprednisolone in the first 24 hours can be helpful. However, there have been more recent papers that show that maybe this isn't the case. So there's not really a clear consensus, but a lot of people tend to not use steroids in spinal cord injury. Controversial, and there's a ton of literature on this that if you guys want to talk more offline, I'm happy to discuss with you. And then, so spinal cord injury is primarily a surgical disease, right? I think we can all agree that giving someone a pill will not improve their spinal cord injury, right? So there are two goals of surgery. Why do we do surgery on someone's spinal cord injury? One is to decompress, right? If they have a fragment of fractured bone that's in their spinal cord, we have to get that out to improve their ability to potentially use their arms or their legs, right? Or to feel their arms or their legs. So that's one, decompression. Stabilization is the other goal. So a lot of people ask, oh, well, if someone is quadriplegic, like they can't move their arms or legs, they can't feel anything below their neck, why would you operate on them? Well, the reason is because we still have to stabilize their spine. If you have an injury like the injury here in this imaging, where you see a huge translation of the bones, and very significant spinal cord injury, you have to stabilize their spine, because even if this patient is wheelchair bound and not able to use their arms or their legs, you want to make sure that this is an incredibly unstable fracture, right? I think you guys can believe me when I tell you. This is what's called a 3-column injury, or basically the worst spinal cord injury you can get. And it's important to stabilize these bones and to put them back in alignment. Even if they're not going to regain function, they still have to maintain their structure, or they can get worse, okay? And you can become further unstable, and you wouldn't even be able to maintain your posture, okay? So even if you're not able to use your limbs, it's really important to be stabilized to maintain your posture, okay? And that your instability doesn't worsen. Okay, so that's a very quick, extremely quick, way too quick summary on spinal cord injury. I can do a much longer lecture on that, but I just want to give you guys a quick taste of what that would entail. So quick question for would having their bending legs relieve pressure up? So that's a great question. Kind of, I see what you guys are saying, kind of in a similar sense of lifting your hip for traumatic brain injury. We don't want them to bend their legs. The reason we don't want them to move at all is because bending their legs can actually tilt their pelvis, okay, which will move the nerves going down to your legs, and it can affect your spinal cord. We don't want them to move at all. We want their legs to be flat. We want them to be in a neutral, straight position. Okay, so this is a good question though. All right, so just to show you guys some interesting cases that I've done recently, to show you kind of how much you can do in neurosurgery. So this right here in the top left, this is a giant aneurysm, or a large aneurysm that we recently treated through endovascular means, through a catheter. We didn't do surgery. There were no incisions, no sutures. This here in the bottom left, this is a large high-grade glioma brain tumor that we took out of a young patient recently. This here is a spinal cord injury case that we did. It was actually an IV drug user who developed a bad infection of the spine called osteomyelitis, who his bones, because of the infection in his spine, the bones actually collapsed, and it caused his spine to just collapse in his neck. And he was no longer able to use his hands or really feel his hands anymore. So what we did is we drilled out all of these bones, and we restored the alignment, as we talked about, of the bones here, and he was able to use his hands again. And he was able to walk out of the hospital and did great. This here, in the bottom right, is a patient with not one, not two, but actually 3 meningiomas, or benign lesions, benign brain tumors. And here, this is me in the middle with my baby shark hat, placing an implant on someone's head of someone who actually had a craniectomy. They had increased intracranial pressure. We had to remove the bone, and they did so well that we were able to put the bone back. And so this is actually a synthetic 3D printed, essentially implant made of something called PEEK. It's a synthetic implant where it's custom fit with a 3D printer based on a CAT scan to their head. And so it fits perfectly, and they get a really nice cosmetic result. So in conclusion, guys, neurosurgery is very challenging. It's so rewarding. I love what I do. It's the reason I'm here still late at night talking to you guys, just to tell you guys about what we do, because I love it. I'm so passionate about it. I've been operating for the past 11 hours, but it's so much fun. As we mentioned, or as I talked about earlier, we operate on really fragile parts of the body. But that's also what makes it so rewarding, is that you can really make a difference in someone's life. Then in the acute care settings we talked about today, we operate on both cranial and spinal emergencies. And we're a unique specialty, and we operate on many different parts of the body. And the brain and the spinal cord are some of the most interesting parts of the body to operate on. There's a high emphasis on technology. We're using new technologies every day. We're using robots now for spine surgery. We're using catheters less than 0.01 millimeters in diameter to help treat an aneurysm. So if you're interested in technology innovation, neurosurgery is definitely a field to look out for. And then check us out. Just to leave you guys with a little quote. I like this. It's kind of a feel-good quote. You never know how many days you have left to figure out how you want to change the world and obsess over it. I think neurosurgery really epitomizes that, and that you just have to do stuff thousands and thousands of times until you feel comfortable. And you really have to have a passion for this, right? It's why you do it day and night. And I hope you guys find your passion, whether it's neurosurgery, whether it's a different field of medicine, whether it's something totally unrelated. Just find something that you're interested in, because right, life is short. You want to have fun doing it. You want to really love what you do. And when I'm not operating on people's brains, I'm taking care of this cute puppy. So this is Noodles. He's my dog. He's a miniature dachshund, or a wiener dog. He's really adorable. And thank you guys so much. You've been an awesome audience. I know I went over, so I'm happy to spend as long as you guys want to answer some questions. If you like the stuff that we talked about, I try to bring up new cases all the time on Instagram. You can follow me. My page is there. And then, as I was mentioning earlier, just Sophia, the lecturer for Thursday, Dr. Chris Riley, is actually one of my best friends, my college roommate. And him and I started a podcast together called RESLIFE that it's now on Spotify. We were on Apple Podcasts, but we got brought on by Spotify to do it. And it's really fun. It's aimed toward pre-medical students as well as medical students. So if you have any interest in medicine, healthcare, not just as a doctor, but as a nurse practitioner, PA, nursing student, it's a lot of like pre-health topics that we bring up. So it's really fun. We love doing it. Check it out if you guys are interested in some of these things. And yeah, thank you guys so much for attending. And I'll just start wheeling off some questions. Feel free, just type in the chat box. Sophia will put it up. we'll just keep going through it. All right, let's see. So do we work with ortho when doing spine surgery? Sometimes we do. Depends on the case. Often we don't. So that's a great question because ortho also performs spine surgeries. This is really important. I was actually deciding between ortho and neurosurgery because I like spine a lot. It's a different type of training. We spend a lot more time during residency doing spine surgery, which is part of the reason why I like neurosurgery a little bit more. Ortho will spend a couple months during a 5-year residency, and then they do a fellowship after in spine. We spend a couple of years doing spine surgeries during our 7-year residency, and you don't have to do a fellowship in spine after finishing to become a spine surgeon if you train in neurosurgery. So that's kind of the difference. But we do overlap in some cases, especially like scoliosis cases, we often do together. Would you say your specialty is high stress? Yes, definitely. We operate on the brain, we operate on the spinal cord. Very high stakes. It can be stressful, but that's why you have to have a good attitude. You have to, we like joke around with each other. We have a good time. Like I love the people who I'm in the OR with because it's very high stress. And so you have to have that release. And for me, that's why hobbies are so important. Why when I'm not in the hospital, I love working out, traveling, doing stuff like that, just because it keeps me sane. Like I'm sure all you guys have your outlets. How and when did you know you wanted to become a neurosurgeon? So I knew pretty early on. I had a really close friend whose family member died of glioblastoma when I was in high school. And I did some neurosurgery research actually at the end of high school. So I kind of knew I liked neurosurgery even as like a 17, 18-year-old. And then when I went to Hopkins, I studied neuroscience. They have a really big neuroscience program there. And it's just, the lectures were amazing. The people I did research with like wrote the textbooks. I had really incredible opportunities that I tried my best not to take for granted. And by the time I went to UC San Diego for medical school, I basically knew I wanted to be a neurosurgeon. So I knew pretty early on. If you're in college, you have no idea. Let me tell you, 90+% of my med school class had no idea what they wanted to do. So do not stress about it. You are the normal people. I'm the weirdo who knew the specialty beforehand. All right. Sorry, I'm trying not to skip questions, but there are just a lot I want to get to. There's some really good ones. See, how many neurosurgeons do MD PhD? To be highly involved in research, the PhD help? That's an awesome question. I would say majority don't have PhDs, but we also have a lot that do. I mean, there aren't as many MD PhDs as MDs or DOs. So I think it's kind of representative. I would say we probably have more MD PhDs than a lot of other specialties just because we are research heavy. However, not as many MD PhDs do it just because it's a long time to do both MD and PhD program and then go into neurosurgery because we're a very long residency. But it definitely helps to have a PhD. It helps that you have a strong research background, that you publish papers, you have a strong basic science background, etc. They're all, you will so if you took the same MD and MD PhD candidate with the same scores and everything, the MD PhD candidate would be stronger just because they have a better background in research. Not sure if that helps. How do you not get queasy? What advice do you have for pre-meds who hate blood? That's a good question. I know it's a funny question, but that's actually a really good question. So I kid you not, when I was younger, I was so squeamish of vomit. I don't know why. It was just vomiting, but always like I had to run away. My mom would always make fun of me. And now obviously like in neurosurgery, a lot of our patients are vomiting. It's just like whatever. You just get desensitized to it, especially with blood. I mean, even if you're not in surgery, you're going to see blood if you're in medicine. If you're a nurse, a doctor of any specialty, you're going to see blood, I guess, unless you're a radiologist. But in medical school, you see blood all the time. You have to draw blood on patients, on yourself. You just get desensitized to it. Yeah, it's just something that you overcome with time. But it's not a stupid question because I was queasy back in the day, and I overcame it. So a lot of people are, and a lot like I know surgeons who passed out the first time they were ever in an operating room, or they like felt weak in the knees the first time they ever saw surgery, and now they're like fantastic surgeons. So don't let that deter you. How do you stay alert during long surgeries? Do you and a nurse surgeon switch off? That's a great question. Another question I get also is, when do you pee? Just in terms of like funny surgeon questions. So it can be challenging. I mean, no one has a forever attention span, right? I will say though, when you're in the operating room and you're the one actually doing the surgery, time goes by very quickly. When I'll think like 10 minutes went by and I look at the clock and it was like an hour. So when you're actually in there and like under the microscope operating, time goes by very quickly. So your perception of time is definitely shifted. And then we don't really take breaks per se. If there's a super long case, like a case like over 8-10 hours, typically different people are doing different parts of the case. For example, if it's a big skull-based case, our ENT colleagues will be doing a lot of the drilling of like the inner ear. So we'll take a break, we'll scrub out during that part, and they'll drill for a couple hours. We'll like go to the bathroom and grab some food or something. But typically we just do the whole case. You just get used to it. You get your routine, like you go to the bathroom before you operate. I always eat something, I drink something. I don't really drink coffee before I operate, just because it's a diuretic and can like make your hands shake. So I pretty much stay away from caffeine before surgery. All right, let's see how we're doing time. All right, we have a few more minutes. Perfect. So how do you cope with telling families of patients their loved ones are in coma, quadriplegic? That's a great question. I get this question basically anytime I do a shadowing session, and it's such an important question. It's really tough, and it's so applicable, not just if you're in neurosurgery, but if you're in medicine, right? If you become any type of doctor, even if it's just in medical school, you're going to break bad news to a patient or family. Even if you're a dermatologist, you're going to diagnose patients with melanoma who it's going to totally rock their world. And it's going to be a huge bomb that you just drop on them. And it's tough, and it comes with time, and I by no means have perfected it, and I'm still working on it, and I think I'll work on it my entire career. You just have to be compassionate, and you have to be empathic, and you just have to lay yourself out there for the family. You have to be honest, you have to be humble, and you have to be straightforward. Don't be around the bush. Just tell the patient what's going on, tell their family what the situation is. Be honest upfront, commit to them that you are going to do everything you can for them and be there as their advocate, and know that they have your support. That's what's important. You can't change what's happened, but you can do your best to make them as well as possible. Another question I get, which is often really tough, is how do you talk to a family when something goes wrong in surgery, right? That's also a really tough question, right? When you operate on the brain, you operate on the spine, a lot can go wrong, as you can imagine. If there's a millimeter difference in a surgery between life or death, things don't always go right, which can be incredibly sobering and very humbling. And it sucks. Like, anyone who tells you it doesn't suck isn't human, or is, a sociopath. It's really tough. But I think it's those moments that really channel you back and really kind of hone into what type of person you are. And those are really the trying moments that, as a doctor, kind of validate, why you're doing this, and the humanistic side of it, right? Is that we're not perfect, and not every surgery goes well. Okay, not every treatment goes well. But going back to the previous point of, you have to tell the patient, the family, that you're there for them, you're gonna advocate for them, you're gonna do everything you can to make the situation better and to help their loved one or to help them, right? And so telling your patients and committing to them that you're going to be their champion is what's important, is what needs to happen. All right, sorry, that was a little tangent. What does my weekly daily schedule look like? It varies a lot. We work during the week. We work roughly like every other weekend. Just depends. Your schedule changes as you become more senior in your training. But we tend to wake up pretty early because we round on our patients before we operate, before we go to the operating room. And then we spend pretty much all day in the operating room. And then we round our patients at night and we go home. So it depends, if we have a short day in the operating room, we can leave at a reasonable time. Or on longer days, we can leave really, really late, like I did yesterday. So it just depends. But like a lot of other specialties, your schedule kind of varies. It bounces around. Like if you work in the emergency department, you'll work like random days, nights, weekends. It just varies. Let's see. How hard is it to shadow neurosurgeons or surgical specialties in general? It depends where you are. It depends on the institution. It depends if there's a pandemic, because it can be really tough when there's a pandemic. Fortunately, shadowing opportunities are opening back up, it looks like. They're not fully back open at my hospital yet. And I'm asked by students all the time, like, if they can come shadow me. We still, even though the pandemic is like moving in the right direction, our health system hasn't allowed volunteers to come and just get people to come shadow yet, unfortunately. Yes, you can absolutely reach out to my Instagram if you have any more questions. I say every day I answer a bunch of people's questions who I've never talked to before, who has some like really interesting questions. That's why I posted there, Neurofitness MD. You can reach out, message me whenever. I might not respond the right way because I might be in a surgery or something, but I'm usually pretty good. In the next like day or two, I usually get back to most people. I'll say, do we have time for like one more question? You tell me, Sophia. Are we done, or do we have time for another question?
I think you answered pretty much most of the questions. Thank you so much for taking the time to present such awesome cases and take the time to answer so many questions. We really, really appreciate it.
Of course. If I missed anyone, I'm sorry. Please, you can message me on Instagram or email, or reach out to me in any way, and I'll try my best to answer your guys' questions.
Yeah, everyone make sure to follow Dr. Schüpper on Instagram and check out the podcast on Spotify. And the Google form has been posted in the chat, which you guys can fill out now for your attendance. That'll close in 30 minutes from now. And stay tuned for our next session on Thursday. And thank you so much once again, Dr. Schüpper. We really appreciate it.
Thank you guys for your time. As always, you guys are the best.